It's always, thank you for inviting me back to speak here. Always fun to talk to a mixed group. I know quite a few of you. One of the things that's puzzling me though is when I look around at the docs, I've known quite a few of you for many years, and you guys are all looking quite a bit older, but I look the same. And I don't get that. How come I look the same? So we're going to zip through a couple of topics. This is, where's the clicker? There we are. So this is, next to pain, this is probably the most important topic we deal with. And we'll just jump right in. We're going to try and learn a practical approach to nausea. There's a qualifier at the very beginning. There's actually very little science to back up most of the stuff that we do in palliative care. You know, we know that these things work, but there are very few studies on these things. Palliative care patients are a tough group to study. You know, they're so sick to begin with, and they often inconveniently die before you complete the study. So recruitment and retaining people in the study is really a challenge. We certainly have lots of practical experience, though. The theoretical approach to this is kind of a nice theory. You know, we should identify the specific cause of the nausea, identify the pathway, think about the receptors, choose the best drug, best route of administration, etc. This is a good slide from Michael Downing that many of us have used over the years that shows all the different, just a little bit on the physiology of nausea and vomiting. And I'm not going to go through the details, but the point is there are 5 or 6 major areas that nausea has an impact on. And this is part of what is partly to help you understand that complicated nausea is actually more difficult and more complicated than pain. I would rather have a difficult pain patient to try and sort out than a difficult nausea patient. It's a harder symptom. So the main areas: chemoreceptor trigger zone, integrative vomiting center, GI tract. Those are the main ones we deal with on the right-hand side, and sometimes in the other areas. There are lists of causes underneath those. For example, in the chemoreceptor trigger zone, cancer toxins, that's kind of a thing we joke about sometimes, but there actually are some chemicals and peptides and things that cancer produces and that can be highly emetogenic or cause nausea. We don't even know what they are, but we'll often have patients where we have looked for everything, and the only reason they seem to have nausea and vomiting is they have cancer. Something is going on there. There's some substance that's being produced that's making them so sick. Medications, gastric causes, distension, brain tumors, increased intracranial pressure, lots of different causes, and many of our patients have more than one cause. In each of those areas, there are different receptors. And this is actually a very simple version of the receptors. But a couple of points: there are different receptors in different areas, but there's also overlap. There are dopamine receptors in different areas, and lots of crossover. This next slide lists some of the drugs that match those receptors. So you can see it's getting more and more complicated as we go along. So there's overlap of the drugs too. Haloperidol is there, haloperidol is down here somewhere. And as a specific example, I put Nausea or Metoclopramide in red, and you can see that it's actually in 5 of the different areas that cause nausea and vomiting. Again, just an illustration of how complicated this is. And now I'm going to try and make it simpler. So how do we actually organize our approach to this? I teach the family medicine residents a lot in Nanaimo and medical students, and my job at this stage is not really to teach them so much the data or the facts that they need to know, but to teach them how to think about problems and how we approach problems. And that's where we're moving now. If you look at different books, they're often organized in different ways, their approach to nausea and vomiting. Or do they look at what's the cause? Are they trying to figure out the receptor? What's the drug class? And often we end up choosing the drug we're most familiar with, or other times it's just a wild guess. You'll see people just kind of pick their favorite drug without really thinking about what the etiology of the problem is. So I think the practical approach is we want to at least try and think about what the syndrome or the cause is, and then choose the best drug for what we think is going on. There are a lot of different drugs in different classes. I've mentioned it's more complicated than analgesia. So let's go through some of the common classes of drugs. So the first one are the dopamine antagonists, and you can think of most of these as antipsychotic medications. I will often tell patients, I'm going to give you a prescription for medication called Haloperidol. This is a drug we use in psychiatry. I'm not giving it to you because I think you're crazy. This is a really good drug for nausea. And we're giving you a very low dose. And that's really reassuring to them. Tons of people go Google this stuff. And then they come back and they think you're a moron because you prescribed a drug for schizophrenia when the problem was actually nausea. So haloperidol is really our drug of choice in this family. It's the most potent with the least side effects. And again, we're using really low doses, 0.5 milligrams, 1 milligram. And for those of you who aren't familiar, a psychiatric dose might be 10 milligrams or 20 milligrams of this drug. So at that low dose, the side effects are good. It's also available in different useful forms, tablets, a colorless, tasteless liquid. You can give it subcutaneously, intravenously, or IM. It's very similar to Stemetil, Prochlorperazine, which is kind of the first drug they use at Victoria Hospice. But you can't use Stemetil subcutaneously. It's too irritating. So to me, I've always used Haldol because then if you need to switch routes, you don't need to change drugs. And that's part of the keeping it simple for patients and families. We sure don't do our patients a favor by making things more complicated than they need to be. And if you can choose one drug that can easily be switched to subcutaneously without having to change, that makes it simpler for them. Other drugs in this class, chlorpromazine is an old-fashioned antipsychotic, which we rarely use. Methotrexate, however, we use as a second or third line. If haloperidol is not working, this can be quite a good choice. And if you remember the previous slide I showed, it targets a whole bunch of different receptors in different locations. And we think of this kind of as a shotgun approach. If your initial drugs aren't working, you can blast away with Nozinan and you'll cover a whole bunch of different receptors and often get additional benefit. Comparing that to haloperidol and prochlorperazine, there's no point in switching between those two because they're very similar. If Haldol is not working, Stemetil is not going to work. So pick something that has additional benefit or different benefit. Olanzapine is on the list there, Zyprexa. This can be quite useful, and there are certainly case reports where that's been useful when the other drugs haven't worked. I mentioned earlier about the receptors. The whole receptor story is really getting complicated, and a couple of days ago I looked up olanzapine, and there are, at last count, 27 different neurotransmitter receptors that olanzapine has an effect on. So the science gets kind of complicated. The next class are the prokinetics, metoclopramide or Maxaran that you would all be familiar with. That's the main one we use. Occasionally we'll use Domperidone, but it's not as effective. It doesn't cross the blood-brain barrier, so you don't get as much of an anti-nauseant effect. However, if people are getting side effects from metoclopramide, and they're getting benefit from it, from the motility, then Domperidone would be a reasonable choice. However, there's no injectable of the Domperidone, so in nausea, that's a bit of a problem. The main side effect to watch out for with metoclopramide is akathisia, which is restlessness. And I'll usually mention that to patients and families, especially if you're going to be pushing the dose a bit. If you're going to go above 10 milligrams 4 times a day, if you're going to try 20 or even 30, you need to mention that to them because they won't usually identify it as a side effect. And you may notice if you go in the room that the patient lies down in the bed, then they sit up, then they lie down, then they turn on their side, then they stand up and go sit in that chair, and then they go lie in the bed again. They're just really restless, and that's often a medication side effect. Antihistamines is another group that we use at times. Gravol we rarely use, Benadryl sometimes. Promethazine, which is Phenergan, it's an old-fashioned drug. Not available in the hospital, but is available in the community. That's a good drug for nausea, especially motion kind of nausea. And we'll come to that in a little while. Anticholinergics, so scopolamine, you're familiar with the transderm patch. I have a personal bias against that. When I went on a fishing trip with a buddy on his commercial boat off the north coast of the Queen Charlotte Islands, it was pretty rough, and I put one of those patches on. It helped my nausea, but my mouth was super dry. Like, I got up 50 times in the night to get a drink of water, and I'd sleep for 5 minutes, and I'd get up. And it also gave me these weird olfactory hallucinations. I was going around the boat trying to find what this weird smell was. My friend thought I was crazy. And after about two nights of the super dry mouth, I finally took it off. I said, oh, I might even rather be sick than this. And within about 30 minutes, that weird smell went away. So some chemical thing that was happening, but it was just the oddest thing. So I'm kind of biased against that. Glycopyrrolate or hyoscine injectable can be used as well for this. Steroids, we actually have no idea how or why steroids work in nausea in most cases, but it can be useful. We often will add this as a third line. If we're just not succeeding, we'll throw dexamethasone into the mix. Cannabinoids, we've used a little bit of Nabilone on and off over the years. That's a cannabinoid pill that we've had for years and years. It can be very useful. The problem originally was the pill was too strong and it would make people too sedated, so we would give them a quarter of a pill. We would mix it in water and give them a little tiny dose. It does come in smaller doses now. Patients now have access to lots of other kinds of medical marijuana. It can be very useful for nausea, and we certainly have no problem if people want to try that. Most people who are feeling sick don't want to smoke things, but there are lots of alternatives now with the vaporizers and different things. Generally, we find with marijuana, older people who never smoked pot when they were young, generally don't like it. It's an interesting phenomenon. But if somebody smoked pot in college even 30 years ago, generally they'll tolerate it and put up with it fairly well. It's kind of an interesting thing. So these are the 5-HT3 drugs. These are the ones in chemotherapy, like ondansetron, Zofran. The guys in the emergency room, this seems to be the first drug they prescribe for any kind of nausea. It's actually not very good for many other kinds of nausea. It's pretty good for chemotherapy nausea, but it's not great in palliative care. We use this occasionally, but it's really more of a fourth line, fourth line drug. It's also very constipating, and docs generally aren't aware of that side effect. It's very constipating. And when you add this to opioids and immobility and all the other dehydration and all the other problems our patients have, this can be a big problem. Benzodiazepines, really no direct antiemetic effect, but people are often just anxious, and it can be helpful to add it to that. And then a few miscellaneous ones. Octreotide, which is anti-secretory. It really reduces the secretions in the stomach. I'll talk about that more when I talk about bowel obstruction in a few minutes. Those other drugs like omeprazole, ranitidine, they also reduce gastric secretions, and sometimes you can improve somebody's nausea and vomiting just by reducing the amount of fluid that's sitting in their stomach. You know, your stomach produces about 4 to 6 liters of fluid a day, and if we can reduce that amount, it can help their nausea and vomiting quite a bit. Non-drug measures, nasogastric tube. If somebody has really bad nausea and vomiting, we'll ask them if they want an NG tube in temporarily. Most, I would say, more than half of them refuse it. They say, no, I had one of those when I had my surgery. I'd rather be throwing up than have that tube in my nose again. But sometimes if their symptoms are really bad, and it'll give you the quickest relief in really bad symptoms. If we haven't had good success with all of our medications, and a person has even more than a week or two to go, we will look at putting in a venting gastrostomy tube if they have persistent, difficult nausea and vomiting. We will get the surgeon to do an endoscopic procedure where they it's basically a feeding tube. We get them to put the biggest size they can get in there, but instead of using it for feeding, we use it to go the other direction. We just vent their stomach. And this is very, very effective for control of nausea and vomiting, at least 90% effective for controlling nausea and vomiting. Some really practical things, letting patients choose the kinds of food that they want, controlling odors. You know, especially up in the main part of the hospital, we've got those 4-bed rooms, and somebody has a nausea and vomiting problem, and the person in the next bed has Clostridium diarrhea and is using the commode. No wonder they're having trouble with more nausea and vomiting. Presenting small portions of what they eat, and we'll do this in the unit sometimes. The nurses will look at what's on the tray outside the room, go in the room and tell the patient what's on the tray and ask them what they would like, and just bring in the foods that they're interested in, because it's pretty challenging if you have sort of underlying nausea and vomiting, and in comes the tray and off comes the lid, and it's hospital gravy with big piles of mashed potatoes and other unidentifiable mashed stuff on the tray. We talk to patients and families a lot about using the palliative diet, and I'll say, well, you know, there's a diabetic diet and there's a cardiac diet, and you're on the palliative diet. That means you eat what you feel like eating. Often they're trying hard, or the family is trying hard to get them to eat more other stuff, and that makes this problem worse. One type of nausea and vomiting that we cannot control with any of our medications is if the person is eating too much. Okay, let's go through a couple of the syndromes, and this is a bit of overlap from earlier, but things caused by various chemicals, drugs, toxins. Best treatment usually is Haldol, something from that group. Motion-induced, and this isn't just when I turn over in bed, I feel more sick. You know, if your stomach is half full and you're kind of rolling around in bed, that doesn't really count as motion-induced. This is more the queasy, dizzy, when I stand up and turn around, I feel more dizzy kind of things. Phenergan is good. Gravol, sort of. Scopolamine can help. We've actually used diclectin. Anybody had nausea in pregnancy in the room? We had a lady a number of years ago. We had tried a whole bunch of stuff for her that wasn't working, and she finally said to us, she was about 65, she said, you know, this is exactly like when I was pregnant. Don't you think I could have that drug? And we thought, well, okay, we'll try anything. It worked like magic. So every now and then we'll pull that drug out and use it. Gastric stasis, when things just aren't moving through their stomach well, metoclopramide's the best drug there. And we'll usually start with 10 milligrams QID. If that's not working and I'm pretty convinced that that's the cause, I'll go to 20 milligrams QID. If they get some benefit, but not complete benefit, I will go as high as 30 or even 40 milligrams QID. But you really need to watch for the side effects then. At those doses, you're quite likely to get akathisia. And I'll even warn them about a possible dystonia, you know, the muscle spasms they can get. Because it's quite scary if they get that. Not harmful, but scary. Warn them. And sometimes just stretching of the liver capsule, constipation, obstruction. Again, usually the prokinetics first and then other drugs. Increased intracranial pressure, that's Decadron. So my general strategy, if there isn't an obvious cause, is I say, do you feel full and bloated, like your stomach is really full, like you ate a big turkey dinner? Or is it more of a queasy, dizzy, car sickness kind of feeling? And then there's my choice. If it's full and bloated, I start with metoclopramide. If it's queasy, dizzy, I start with Haldol. And this would be sort of a common way we would work through it. Might start with metoclopramide, add Haldol if they're not better, maybe add an antihistamine, add a steroid. And often we're adding these drugs. It's not one drug, stop it, do a new one, because they're often additive effects. So usually we keep kind of adding them on. They may end up on 3 or even 4 different anti-nauseants. We finally get them controlled. And then after a couple of days, we'll start subtracting drugs. We'll think, okay, well, maybe the metoclopramide actually didn't help, so let's drop that one. Then we wait a couple of days, and then we'll try dropping another one. We have a chart from the Victoria Hospice manual in our room where we work on our computers, and it has all the different drugs for nausea. And when we get sort of down to the 3rd or 4th drug, we'll sometimes go in the room and just look at the chart and pick something from a class that we haven't tried before. That's, if you just, when you're stuck and you're kind of working through different ones, you just want to make sure you pick something different that you haven't tried before, or that isn't a close relative of something you've already tried before. Intractable nausea, very occasionally their symptoms may be terrible enough that they actually require some sedation. The venting tube, again, if they're well enough and it's technically possible, that's a great technique. But if somebody just has days to live, that's not a practical alternative. So just to summarize a few things: optimize the dose depending on the side effects, reevaluate the causes, add drugs that target a different receptor. Sometimes continuous medication is more effective, and occasionally we'll run metoclopramide as a continuous infusion. And don't forget the practical measures like reducing intake. Sometimes when we're struggling to control nausea, then we find out, one of the nurses will say, well, you know, his wife is just cramming food into him every time she's in the room. Okay, so that's the end of the nausea talk. I think, yep, Steve?
I'm curious how you use propofol as an anti-nausea. Does it make the patient unconscious?
No, and in the past, when the health authority was a little simpler in the good old days, we actually had permission to use propofol in our unit. And it's been shown in lots of case reports to be very good at low doses for controlling nausea. And the guys in the ICU will support that as well. But things have changed and we're not actually allowed to use, it's restricted to a doctor, not a location. So if we needed to use propofol in our unit, Alan Berkman, the anesthetist, has said he'll come and write the orders for us. It's really low dose, yeah, and it can be very, very effective. It's not something we've actually used, but I think in palliative care you always have to have something else you can use, right? You always know what's one more thing you can try if you have to. I don't think you'll be using that in hospice or in the home. Garth?
What was the dose of olanzapine you use? Is it very small as well compared to?
2.5 usually, and the other advantage of olanzapine is it has that little wafer Zydus. It's a little dissolving thing, so that they can tolerate. You don't have to use an injection.
Robin, have you, excuse me, have you ever had a call? It's me.
Oh, Dr. Spry.
Not so much in PCU, but in the community. Have you ever had a call from a pharmacist that's saying you can't prescribe Maxaran and Haldol together? Because there's a problem.
I don't think I personally have, but I think some of us have. And it's just that the risk of the Parkinsonian side effects goes up if you're combining those drugs. But we're generally, especially with the Haldol, we're using low doses. Just be aware if you start combining them that you're more likely to get some side effects. Yep.
Can I ask a pain-related question?
Sure.
In the previous slides, we saw that you could use fentanyl in a patient who's opioid allergic, but you can't use fentanyl in a patient who's opioid naive. So how would you initiate it?
So most of the patients, first of all, almost nobody is truly opioid allergic, right? Like if somebody says to me, I'm allergic to morphine, I really am, I'll just say, oh, okay, and I'll give them hydromorphone. Like without even, a true morphine allergy is 1 in a million. And, but if you are actually worried, you just want to choose a synthetic one, something different. Fentanyl, you could try some test doses if you were really worried. If they were truly opioid naive, you could try some test doses of fentanyl sublingual. Give them 10 micrograms, 25 micrograms. Or you put on the 12 patch. You can give a lower dose if you had to. You can overlap it on a piece of tape. Then they'd be getting 6 micrograms an hour, right? So there's ways around it. Yeah. The disasters are not palliative care patients who get a patch. It's like a 12-year-old with a dental problem gets a 25 microgram Duragesic patch put on. Those have been the catastrophes, not our patient population. Okay, Roma?
Residential care, we can get olanzapine and Haldol topical.
Oh, with the gel? Sure. Yeah, we've been using a fair number of topical medications. In general terms, I haven't been a huge fan of that because I think I think the pharmacies put tons of stuff in compounding creams that are not really necessary. But occasionally there's an indication where you're just really having trouble getting a drug into somebody. We've been using topical methadone. We've actually published a letter on using topical methadone because injectable methadone has become impossible to get. And we've used Nosanan. You probably remember that patient. We had a really agitated patient, and he would punch the nurses every time they came near him. And so they couldn't, and it just sort of escalated because, 4 nurses would go in, hold him down, and give him an injection. So the next time when the nurses came in, he was ready for them because it was an unpleasant experience. So we thought of getting Nosanan in a gel, and then the nurse could go in by herself and just sort of take his hand and just rub him on the arm and give him a big whacking dose of Nosanan. So that worked really well. So there are roles for it. Okay, should we move on?